The next slide shows the key recommendations of what's called the Surviving Sepsis Campaign, which is a group, an international group, that tries to codify these best practices and present them as modules that hospitals can implement to better take care of patients who have sepsis and severe sepsis. And these just show some of the key recommendations. Obviously, early detection that the patient has sepsis is important, and quick resuscitation if the patient actually is already deteriorated. Treating the infection with the appropriate antibiotics. Making the diagnosis is often helped by doing blood cultures and by certainly examining the results of the cultures in the microbiology laboratory. And then, of course, identifying and removing the source of infection is important. But a lot of focus has been given to stabilizing the patient even after all these things have been done. And these two recommendations relate to a whole slew of different approaches to maintaining the patient's blood pressure and also making sure the patient's breathing is appropriate. This means getting the patient on a ventilator as soon as they should be on a ventilator, and it also means getting the patient off the ventilator as soon as they should be off the ventilator. And then I think especially those of us in the clinical lab are familiar with this focus on glycemic control in critically ill patients, and that's also been advocated as a key recommendation for the Surviving Sepsis Campaign. So I think with that, we'll ask the second poll question, which has to do with the participants being involved in these sepsis protocols at their institution. So please vote if you are involved in the sepsis protocol at your institution or not. Okay, so actually that's encouraging that a significant minority are. But again, as I was about to say, I think I would not be surprised if a majority of the people are not involved. And I have to say that I was one of you. I'm a laboratory director at an academic medical center, and I was certainly aware that Stanford was involved with implementing many of the recommendations of the Surviving Sepsis Campaign, but I was not specifically involved in the protocol. Several people from the laboratory did become involved. May Louie, who's our director of point-of-care testing, and Will Flores, who's our supervisor in special coagulation, invited themselves to the meeting of the nurses who were involved in setting up these protocols at Stanford, and then invited me to join. Now, the next slide shows you the markers that are used for the diagnosis of sepsis. We've already discussed procalcitonin and CRP as the two markers that are used for bacterial infection identification, and those are also used for diagnosis of sepsis. Again, when you're looking at these receiver-operator curves, you have to take into account the selection bias potentially of the study. For instance, this study was done in a group of about 100 sequential admissions to an intensive care unit, and almost everybody had the systemic immune response syndrome, and about half the people had sepsis. So the prevalence of sepsis in this population was very high. You may not get the exact same results when you look at receiver-operator curves in studies where there's different prevalence. But I was interested in what Stanford was doing because Stanford was interested in using lactate as a marker of sepsis, and it was very clear right away that we needed to sort of move to one of these other markers. Now, before I talk about the use of procalcitonin, this bioMérieux, the company sponsoring this webinar, wanted me to make sure to show you this current FDA claim. You can see it there. Actually, PCT, I believe that the FDA claim is the same for all the companies that have a commercially available procalcitonin assay. And it's to be used in conjunction with other laboratory findings and other clinical assessments to aid in the risk assessment of critically ill patients on the first day of admission for suspected sepsis. The procalcitonin assay has undergone some evolution over the past decade. The assays that were responsible for most of the studies that were done in Europe in the 1990s, and even the major part of this decade, used an assay that was a batch analyzer assay. And now we have available several different versions of assays that are random access. They're both immunoassays, and it is true that the newer assays are more analytically sensitive. They can measure procalcitonin down to lower levels. But the cutoffs for being suspicious about the risk of sepsis or being very confident about the high risk of severe sepsis haven't really changed. And I think that the major advantage of the newer assays is really their ability to be random access. This was a major obstacle to utilizing procalcitonin in the past because these are the types of tests like STAT tests that are done in the emergency department patients or in intensive care unit patients that you really need to do right away as soon as you get the specimen and report it with that very fast turnaround time. And now we're able to do that with procalcitonin. These are the three initiatives that we're currently working on at Stanford. As I said, Stanford has been implementing, they're called bundles, these recommendations of the Surviving Sepsis Campaign for about 5 years. But we're interested now in focusing on trying to identify people early, and there's 3 ongoing protocols, one in the emergency department and one in the ICUs. These are still in the discussion phase, but this year in 2009, Stanford, led primarily by the nurses in the medical and surgical units at Stanford, we're implementing a program to increase awareness of who may be at risk of developing sepsis. And a lot of this is due to the nurses trying to standardize how they look for early clinical warning signs. But they were planning to use lactate as the laboratory parameter, and after a number of discussions, we convinced them to use procalcitonin in place of lactate, especially given the better performance that procalcitonin has in a large number of studies. And this next slide basically summarizes Stanford's success. This is without any attempt at early recognition using a laboratory marker. This is just the implementation of those surviving sepsis bundles, and you can see that we've had a great deal of success reducing the mortality in patients at Stanford from somewhere in the neighborhood of 50% down to somewhere in the neighborhood of 30%. And we're hoping that with this new protocol that we're implementing around the first of the year to try to monitor all the patients in the hospital for early warning signs of potential for developing sepsis, that we'll be able to get this down even lower, and we're going to certainly study that and report on that. I'm pretty confident that the use of procalcitonin will be a major advance here in trying to recognize patients who are at risk much earlier than we currently are. That's pretty much all I was going to say about procalcitonin. I did want to also just talk about a couple of other types of sepsis markers, and this slide should be very familiar to anyone in the audience who's working in the hematology area. In fact, the hematology technologists have been able to identify people at risk of sepsis for many, many years by seeing these toxic granulations and Dolly bodies. When the inflammatory cytokines go into the blood, they stimulate the neutrophils that are circulating, and that stimulation causes their granules to have more acid and change their color, and they actually get filled with acid and proteolytic enzymes, and they start to leak out, and that forms this thing called a Dolly body. Over the last couple of years, there's been some interest in using flow cytometry to recognize this process and recognize it even earlier than the toxic granulations, and that's using this molecule called CD64. CD64 is a Fc receptor for immunoglobulin, and it's upregulated very early in the activation of the poly. This has been used to identify people who are at risk of developing severe sepsis as well. There's actually a number of different polymorphonuclear leukocyte-related proteins that have been looked for. This one, which stands for triggering receptor expressed on myeloid cells, is a protein that's involved in the signal transduction when the neutrophil is activated, and it does sort of come off the cell and can be detected in the serum. I think that there's been some mixed results with this marker. And then a relatively new marker is this marker called heparin binding protein, which is also called azoracidin, and it's a protein that is actually leaked from the granules and may actually be involved in the leakage of plasma and contribute to the hypotension that's seen in patients with severe sepsis. And then finally, I want to this is a very complicated slide, but I just wanted to use it to mention the importance of the coagulation system and coagulation markers in sepsis. I think everyone knows that one of the major problems that people with sepsis might encounter is disseminated intravascular coagulation, DIC. And one of the reasons why that happens is that when you have inflammation in the vessels, remember that when you have bacterial infection, you're going to have these neutrophils and monocytes and T cells coming out of the blood into the site of infection. Well, they form a stimulus for platelet aggregation and clot formation. And the other thing that happens is that the normal molecules that would sort of put a brake on coagulation, which might be present on the endothelial cell, are missing. For some reason, this molecule here in the green called TM, or thrombomodulin, that's a molecule that's usually expressed on endothelial cells, and it binds to thrombin generated during the clotting process, and that activates protein C, and activated protein C is able to inactivate activated factor V, and that kind of puts the brakes on the coagulation system. In sepsis, you basically have more coagulation occurring and you have less braking on the process, and so you actually have a setup for DIC. And in fact, activated protein C is used as a drug to treat patients with sepsis. And then this almost next to last slide is just another receiver-operator curve from a study that was done. This study is not actually sepsis. This is actually, again, differentiating bacterial from non-bacterial infection. But I wanted to just make 2 points with this slide. One is that here's a receiver-operator curve where PCT doesn't do quite as well as CRP. So again, you have to view these receiver-operator curves in the studies with some critical looking at what the prevalence of sepsis is and how the patients were selected. But the other point I wanted to make, which I think is a key one, especially after talking about these other markers like the markers on neutrophils and markers of coagulation, we may want to wind up using multi-markers. You can see in this study using 3 or even 6 of these markers was better than using any single one. I think we're still going to use lactate, but I think we're going to look at whether lactate and procalcitonin is better than lactate alone or procalcitonin alone. And the future of identifying patients with sepsis or at risk of severe sepsis probably is going to involve a multi-marker approach. So we have one more poll question, which is the poll question number 3.